Urinary bladder cancer, role of MR imaging. Urinary bladder cancer is a heterogeneous disease with a variety of pathologic features, cytogenetic characteristics, and natural histories. It is the fourth most common cancer in males and the 10th most common cancer in females. Urinary bladder cancer has a high recurrence rate, necessitating long-term surveillance after initial therapy. Early detection is important, since up to 47% of bladder cancer-related deaths may have been avoided. Conventional computed tomography and magnetic resonance imaging are only moderately accurate in the diagnosis and local staging of bladder cancer, with cystoscopy and pathologic staging remaining the standards of reference. However, the role of newer MR imaging sequences in the diagnosis and local staging of bladder cancer is still evolving. Substantial advances in MR imaging technology have made multiparametric MR imaging a feasible and reasonably accurate technique for the local staging of bladder cancer to optimize treatment. In addition, whole-body CT is the primary imaging technique for the detection of metastases in bladder cancer patients, especially those with disease that invades muscle. Bladder cancer is one of the most common malignancies of the urinary tract and occurs 3 to 4 times more frequently in men than in women. Has a high recurrence rate, necessitating long-term surveillance after initial therapy. In this article, we will discuss urinary bladder cancer in terms of pathologic features, genetic characteristics, clinical staging and management, treatment and imaging considerations, with emphasis on the value of conventional and newer imaging techniques for diagnosis and local staging. Pathologic features. About 90% of bladder tumors are urothelial in origin, transitional cell carcinomas. Squamous cell carcinomas accounts for 6 to 8% of all bladder cancers. Adenocarcinomas are rare and typically represents urachal cancer. Up to 25% of urothelial cancers have a mixed histology that includes small cell neuroendocrine, micropapillary, which resembles serous papillary cancer of the ovary, sarcomatoid and plasmacytoid components. These variants have substantially worse prognosis than do the pure urothelial cancers. The most common etiologic factors for urothelial tumors are cigarette smoking and occupational exposure to chemical carcinogens such as aniline dyes. Cigarette smoking is thought to be the causative factor in 50 to 60% of men and 1/3 of women who develop bladder cancer. The relative risk of recurrent smokers for death from bladder cancer is 3.3 in men and 2.2 in women. Iatrogenic risk factors for urothelial tumors are therapeutic irradiation of neighboring organs and the use of alkylating agents. Although it's rare, there is a genetic predisposition to the development of urothelial tumors in some families. Risk factors for squamous cell carcinoma include long-term catheterization, non-functioning bladder, urinary tract calculi, and chronic infection by schistosoma hematobium. Urothelial tumors are classified as either invading muscle, non-papillary, or not invading muscle, superficial or papillary. Approximately 80 to 85% of urothelial tumors are non-muscle invasive. These are low-grade lesions, can be multifocal, and arise from a hyperplastic epithelium. They generally have a good prognosis and rarely evolve into an invasive cancer, although urothelial recurrence rates are about 50%. Approximately 20 to 25% of bladder cancers are muscle invasive, arise from severe dysplasia or carcinoma in situ, and have a higher histologic rate. Non-muscle invasive urothelial tumors have a higher rate of recurrence than do the muscle-invasive variety. If left untreated, they are a precursor of muscle-invasive tumors. Nearly all cases of squamous carcinoma and adenocarcinoma of the bladder are invasive at the time of diagnosis. These two types of bladder cancer can carry a worse prognosis than do the urothelial tumors, even with aggressive surgical therapy and chemotherapy. Genetic characteristics. Non-muscle invasive and muscle invasive tumors behave differently because they harbor distinctive genetic defects and arise along two separate pathways. Non-muscle invasive tumors are characterized by activating mutations in the HRAS gene and fibroblast growth factor. These genes play a role in modulating the RTK receptor tyrosine kinase and RAS signaling pathways. Activation of the RTK and RAS pathway leads to the development of malignancy. Patients with non-muscle invasive tumors may benefit from RTK-RAS pathway inhibition. Muscle-invasive tumors are characterized by structural and functional defects in the p53 and retinoblastoma tumor suppressor pathways. Both of these proteins play critical roles in the cell cycle control. These high-grade tumor variants tend to metastasize despite radical surgery, but affected patients could potentially benefit from replacement therapies that restore the function of p53 and retinoblastoma. On the basis of the molecular pathogenesis of bladder cancer, several U.S. Food and Drug Administration approved biomarkers are available for predicting disease recurrence and survival after radical cystectomy. To date, however, none of the approved biomarker assays eliminates the need for diagnostic or surveillance cystoscopy. Normal anatomy of the urinary bladder. The urinary bladder is primarily an extraperitoneal structure with peritoneum covering only the superior surface of the bladder dome. The orifices of the ureters at the uretero-vesical junction are joined by an elevated ridge covered by mucosa, the interureteric ridge. The bladder trigon is a triangular region in the inferior wall, marked at its corners by the uretero-vesical junction and the urethra. The four defined layers of the bladder wall are the urothelium, which lines the bladder lumen, the hyalovascular lamina propria, submucosa, the muscularis propria, and the outermost serosa. The urothelium is thin relative to the full thickness of the bladder wall. The thickness of the hyalopvascular lamina propria varies with the degree of distension of the bladder. The muscular layer of the bladder is also referred to as the detrusor muscle and consists of a complex network of interlacing smooth muscle fibers. The inner and outer muscle fibers tend to be oriented in a longitudinal fashion, but distinct layers are usually not discernible. The outermost serosa is formed by a loose layer of connective tissue. Clinical staging and management. Patients with bladder cancer most commonly present with painless hematuria, 80 to 90% of cases. The initial evaluation of a patient who presents with hematuria is not uniform. Some institutions perform computed tomography urography for triage prior to cystoscopy, whereas others use cystoscopy as the first line of investigation. Nevertheless, cystoscopy and CT are complementary and have a definite management role in patients who present with hematuria. Magnetic resonance imaging of the pelvis is usually performed for T-staging once bladder cancer has been diagnosed, although its use is not widespread. Cystoscopic staging to evaluate the urinary bladder and urethral mucosa is an important part of pretreatment planning. Cystoscopic biopsy of suspicious-looking bladder lesions is performed to assess the pathology, grade, and depth of these tumors. Transurethral resection of bladder tumor is performed for complete resection of superficial bladder tumors and is also used for deep biopsy to assess for muscle-invasive tumors. Cross-sectional imaging is usually performed afterwards for disease staging in patients who are thought to have solid tumors. Treatment decisions and prognosis for bladder cancer are based on the depth of muscle invasion by the tumor, degree of differentiation of the tumor, and presence or absence of metastatic disease. Ureteroscopy is performed in patients with positive selective urethral cytologic findings or evidence of upper tract disease at CT urography. Biopsy is performed of all suspicious-looking lesions. Bladder cancer is staged using the TNM staging system. In this system, T stage is based on the degree of invasion of the bladder wall. TURBT is usually chosen as the initial treatment for early-stage urinary bladder carcinoma. Tumors of stage T2 or greater are treated with partial or total cystectomy or with adjuvant therapies, since TURBT for invasive tumors often results in local tumors recurrence. And therefore, preoperative differentiation between stage T1 tumors and stage T2 or greater tumors is crucial for the appropriate choice of effective treatment options. Treatment: non-muscle invasive disease. Non-muscle invasive tumors are usually treated with TURBT. Despite being the primary staging technique, clinical staging understage 30 to 50% of bladder cancers. As a result, in patients with bulky TA lesions or T1 tumors, the current trend is to perform repeat TURBT 2 to 6 weeks after the first TURBT. At the repeat TURBT, residual disease is seen in 1/3 to 3/4 of patients. At many centers, lesions that carry an increased risk of recurrence are treated with adjuvant intravesical chemotherapy, for example with mitomycin C or gemcitabine, or immunotherapy. Although response rates are about 80–70% of patients with non-muscle invasive bladder cancer develop recurrence within 3 years of treatment, and 10–20% of which are invasive. Muscle invasive disease. For muscle invasive tumors, radical cystectomy is the established treatment. The 5-year survival rate for patients who have undergone cystectomy varies from 27% for stage T4 disease to 66% for stage T2 disease. There is evidence that the extent of lymphadenectomy correlates with survival, with meticulous lymphadenectomy resulting in a 30% cure rate for node-positive cancer. The concept of the sentinel node is not generally accepted for bladder cancer, thus extended bilateral lymphadenectomy is required. Robotic cystectomy is increasingly being practiced, although long-term oncologic outcomes following this surgical technique are not yet available. Up to 50% of patients with muscle-invasive bladder cancer eventually develop metastatic disease.